Female infertility is defined as the inability to achieve pregnancy after 12 months of unprotected intercourse in women younger than 35, or 6 months in women 35 or older. The causes are divided into two factors: female factors and male factors. Female factors may be divided into three categories: ovulatory dysfunction, tubular dysfunction, and cervical or uterine dysfunction. Male factors may be divided into two categories: reduced sperm quality or production, and tubular dysfunction. There may also be unexplained or mixed factors. Ovulatory dysfunction may be due to polycystic ovary syndrome, hypogonadotrophic hypogonadism, or hypergonadotrophic hypogonadism. Tubular dysfunction, pelvic inflammatory disease, endometriosis, previous sterilization, or previous pelvic or abdominal surgery. Cervical or uterine dysfunction may be due to congenital abnormalities, fibroids, treatment for cervical carcinoma, or Asherman syndrome. Reduced sperm quality or production may be due to Y chromosome microdeletions, varicocele, hypergonadotrophic hypogonadism, or hypergonadotrophic hypogonadism. Tubular dysfunction may be due to varicocele, congenital abnormality of vas deferens or epididymis, previous sexually transmitted infection, or previous vasectomy. Men with hypogonadotrophic hypogonadism are given injections of HCG several times a week. Recombinant FSH is also needed if hypogonadism is of prepubertal origin. Varicocele removal can improve semen quality. If oligospermia or poor sperm quality, extraction of sperm from the epididymis for IVF is done, an intracytoplasmic sperm injection is given. If azoospermia, use of donated sperm may be considered. Polycystic ovary syndrome causes infertility primarily through chronic anovulation. Insulin resistance drives hyperinsulinemia, which stimulates ovarian theca cells to overproduce androgens. Concurrently, altered GnRH pulsatility elevates LH while suppressing FSH. This high androgen and low FSH environment arrests follicular maturation, preventing dominant follicle selection and egg release. Hypogonadism causes female infertility by suppressing the hypothalamic pituitary ovarian axis, leading to deficient gonadotropin secretion, FSH and LH. Without adequate FSH and LH stimulation, ovarian follicles fail to mature properly, estrogen production drops, and ovulation is prevented. Consequently, eggs cannot be released for fertilization, resulting in anovulatory infertility and amenorrhea. Pelvic inflammatory disease causes female infertility primarily through ascending upper genital tract infections, commonly from pathogens like Chlamydia trachomatis or Neisseria gonorrhoeae. The resulting severe inflammation triggers tubal mucosal destruction and fibrosis, leading to chronic tubal occlusion or adhesions. This mechanical blockage prevents the ovum and sperm from meeting, or disrupts proper zygote transport to the uterus, causing tubal factor infertility. Endometriosis causes infertility via multiple mechanisms. Pelvic adhesions and scarring distort pelvic anatomy, impairing oocyte capture by fallopian tubes. Chronic peritoneal inflammation alters the follicular fluid microenvironment, negatively affecting egg quality. Furthermore, immunologic factors and altered endometrial receptivity disrupt proper embryo implantation, while hormonal imbalances can further compromise overall ovulatory and tubal function. Previous female sterilization permanently prevents conception by intentionally interrupting the pathway between the ovary and uterus. Procedures like tubal ligation, clipping, or electrocoagulation mechanically block, cut, or seal the fallopian tubes. This physical barrier stops oocytes from meeting sperm and prevents fertilized embryos from reaching the uterine cavity for implantation, rendering natural pregnancy impossible. Uterine fibroids impair fertility primarily through anatomical distortion. Submucosal fibroids alter the endometrial cavity, disrupting embryo implantation and vascularization. Large intramural or subserosal fibroids can compress or block the fallopian tubes, impede sperm transport, and cause local myometrial contractions that interfere with gamete migration and normal uterine transport. Treatment for cervical carcinoma often causes infertility through radical surgeries like radical hysterectomy, which removes the uterus, cervix, and parametria. Pelvic radiation therapy damages ovarian reserve, causing premature ovarian failure, and induces severe uterine fibrosis. Chemotherapy compounds this by depleting oocytes, permanently halting reproductive function and preventing future gestation. Y chromosome microdeletions eliminate critical azoospermia factor genes located on the long arm. These regions encode proteins essential for spermatogenesis, germ cell proliferation, and maturation. Their absence disrupts normal testicular tissue function, leading to severe spermatogenic failure, severe oligospermia, or complete azoospermia, which directly impairs male reproductive capacity and causes infertility. Varicocele causes male infertility primarily through increased scrotal hyperthermia and venous stasis. The abnormal dilation of pampiniform plexus veins raises testicular temperature, impairing spermatogenesis. Additionally, it leads to testicular hypoxia, accumulation of metabolic waste products, and reflux of renal/adrenal toxins. This oxidative stress damages sperm DNA, reduces motility, and alters morphology, ultimately compromising overall semen quality. Sexually transmitted infections cause male infertility primarily by inducing acute or chronic inflammation of the reproductive tract, such as epididymitis, orchitis, or prostatitis. Pathogens like Chlamydia trachomatis or Neisseria gonorrhoeae can lead to fibrotic scarring and permanent obstruction of the vas deferens or epididymis. Furthermore, reactive oxygen species and leukocytospermia impair sperm motility, damage DNA integrity, and severely compromise overall sperm quality. A vasectomy causes male infertility by surgically interrupting the vas deferens, the bilateral muscular tubes responsible for transporting mature sperm from the epididymis to the ejaculatory ducts. By cutting, tying, sealing, or blocking these conduits, sperm are permanently prevented from mixing with seminal fluid during ejaculation. Although spermatogenesis continues and the testes remain functional, the physical barrier halts sperm delivery entirely, rendering the ejaculate azoospermic. Clinical assessment. In both men and women, sexual history and history of previous pregnancies, relevant infections and surgery have to be taken. In women, irregular or infrequent menstrual periods indicate anovulatory cycles in the woman, like PCOS. In men, examination of the testes has to be done to confirm their presence and to identify structural abnormalities like small size, varicocele, or absent vas deferens. Investigations are performed after a couple has failed to conceive despite unprotected intercourse for 12 months. In male, semen analysis has to be done to assess sperm count and quality. These are the investigations done in female. Confirmation of ovulation by an elevated serum progesterone concentration on day 21 of the menstrual cycle. Transvaginal ultrasound to assess uterine and ovarian anatomy. Tubal patency by laparoscopy or hysterosalpingography. In vitro assessments of sperm survival and cervical mucus in cases of unexplained infertility. Management. Couples should have regular sexual intercourse, ideally every 2 to 3 days. In women with polycystic ovary syndrome, clomiphene is given to induce ovulation. If gonadotrophin deficiency or unsuccessful antiestrogen therapy, direct stimulation of the ovary by daily injection of FSH, and an injection of HCG or LH to induce follicular rupture at the appropriate time. In hypothalamic disease, pulsatile GnRH therapy with a portable infusion pump can be used. Monitoring of response. For clomiphene, ultrasound monitoring for at least the first cycle is needed. During gonadotrophin therapy, monitoring by transvaginal ultrasonography and blood estradiol levels is mandatory. If patients fail to respond to ovulation induction or primary ovarian failure, using of donated eggs or embryos, surrogacy, and adoption may be considered. In vitro fertilization may be used in unexplained cases of prolonged infertility. Thanks for watching this video. Please like, share, comment, and subscribe to this channel.